Today we are going to discuss about, let's take a case. Okay, suppose a patient, a 60-year-old male patient came to the OPD with chief complaints of incomplete voiding of urine or retention of urine and nocturia. Night times he is waking up for urination up to three times, and even though he has emptied his bladder, again there is a feeling of fullness in the bladder. Then what do you suspect of? So all these symptoms corresponding to a condition known as immediately we'll think of this benign prostatic hyperplasia, so which is common in age group of 60 to 70 years. As in this case, he is 60-year and male patient of incomplete voiding of urine, nocturia, hesitancy, and episodes of near retention, urinary incontinence. So you will directly go into BPH. So let's discuss today BPH. Okay, so it is common in the age group of 60 to 70 years, and BPH affects both glandular epithelium and connective tissue stroma. Here both the patient complains of both dynamic and static complaints. So dynamic symptoms will be hesitancy, poor flow, not improved by straining, dribbling even after micturition, intermittent stream, stops and starts, poor bladder emptying, episodes of near retention. And static means symptoms of storage. They are frequency, nocturia, urgency, urgent incontinence, and nocturnal incontinence. Okay. So mainly we should be going to study like from symptoms. So what is the cause of these symptoms? So first you have to question yourself. So first you should be making this topic interesting. So first you have to go through the symptoms, and you should question yourself why this is occurring. Okay, then you should go for etiology, and then you should go for pathology, right? So it is involuntary hyperplasia due to the disturbance of the ratio of estrogens and testosterone. So how the testosterone is synthesized? So first we have hypothalamo pituitary and gonadal axis, HPG axis. So from hypothalamus there will be pulsatile release of GnRH. The GnRH will act on the anterior pituitary, right? Anterior pituitary, there is vascular supply, means vascular connection between the hypothalamus and anterior pituitary, right? Through this GnRH will act on the anterior pituitary, and then from anterior pituitary we will get LH and FSH, right? This LH is helpful for releasing this testosterone. Okay, this testosterone on 5-alpha reductase action, it will converting into dihydrotestosterone. That's okay. So which is 5 times more potent than the normal testosterone. Okay. So BPH is a benign neoplasm, and it is also known as fibromyoadenoma. Adenoma means glands are involved. So fibromuscular layer also involved. So it is also known as fibromyoadenoma. Okay. So both stroma and glands are involved here. So which glands? Submucosal glands are involved, and periurethral transitional zone with stromal proliferation and adenosis will occur. Okay, which compresses the peripheral zone and enlarges the lateral zone. Here this prostate anatomy like that they given. This is the prostate lobe, this is lateral lobe, this is median lobe, this is prostatic urethra, right? So this is retention of urine in the bladder due to BPH. This is bladder, there is urine retention. So okay, coming to pathology, it involves median and lateral lobes of the prostate. So it involves the adenomatous zone of the prostate, submucosal glands. Median lobe enlarges into the bladder. Lateral lobes narrow the urethra, causing the obstruction. Urethra above the veromontanum means urethral eminence will be there, some eminence near the urethra, which is known as veromontanum. So it gets elongated and narrowed. Bladder initially takes a pressure burden, which causing the trabeculations, accretions, and later diverticular formation. Enlarged prostate will compress the prostatic venous plexus, causing a condition which results in the vesical piles, if leading to the hematuria. Okay. So if you suspect that BPH is a main reason of hematuria, then you will call that terminology as decoy prostate. Kidney and ureter involvement, if it is there, resulting in the hydroureter and hydronephrosis due to the back pressure. Secondary ascending infection can cause acute or chronic pyelonephritis. Even in pathology, we had studied how the retrograde stasis of urine will lead to pyelonephritis. Okay, retrograde pressure leading to pyelonephritis. So often severe obstruction can lead to obstructive uropathy and renal failure. BPH may cause impotence. So what are the features coming? The patient will be coming into cystitis or urethritis, and he may complaints of due to these he may complaints of frequency of urination, urgency, hesitancy, nocturia, overflow and terminal dimpling, and difficulty in micturition with weak stream and dribbling of the urine, pain in the suprapubic region. Okay, due to pain will be seen. Okay, due to cystitis and hydronephrosis, acute retention of the urine, chronic retention also can occur in the BPH, retention with overflow, high pressure, chronic retention and functional obstruction, impaired bladder emptying with its problems like cystitis, urethritis, stone formation, residual urine, hematuria, renal failure, prostatism, combination of symptoms like frequency both day and night, poor stream, delay in starting and difficulty in micturition. There will be before also we saw there is pain in the suprapubic region. So there is tenderness in the suprapubic region, and due to the retention of the urine, the bladder appears enlarged. Okay, into chronic retention, hydronephrotic kidney may be palpable. Okay, should be doing per rectal examination also. In case of enlarged prostate, you must do per rectal examination, and you should be asking the patient to empty the bladder before you do per rectal examination. Okay, features of urinary infection, like due to stasis of urine, there may be bacterial infection. So due to this, there may be inflammation and fever, chills, burning, micturition may be occurring. Okay. So these are the symptoms as we had already discussed, and we went to the pathology. So did you understand why these are causing? Due to the enlarged prostate, it is making the urethra to get narrowed. So there is dribbling and there is infrequent emptying of the bladder, which makes the patient to feel like again going to washroom. Okay. Differential diagnosis of stricture urethra. In case of stricture urethra also, there is narrowing of the urethra. So you should be ruling out these. Bladder tumor, carcinoma prostate, neurological cause of retention of urine like diabetes mellitus, stapes dorsalis, we will be seeing it in syphilis, disseminated sclerosis, Parkinson's disease, idiopathic destructive activity, bladder neck stenosis and bladder neck hypertrophy. So coming to the investigations, urine for microscopy and culture sensitivity. In case of any infection, to rule out, you should be doing urine culture also. Blood urea and serum creatinine. USG abdomen, look for presence of residual urine, and urodynamics, like urine flow rate normally is greater than 15 ml per second. 10 to 15 ml is okay, but less than 10 ml is low. Voiding pressure less than 60 centimeters of water is normal, 60 to 80 is equivocal, and greater than 80 is high. Should be doing cystoscopy. Transrectal ultrasound is used to find out nodules, possibility of carcinoma prostate, not done routinely. Acid phosphatase, prostate specific antigen, and you should be observing the kidney function through IVU and serum electrolytes. Okay, management, how you will manage. So acute retention of urine requires urethral catheterization. If urethral catheterization is failed, you should be doing suprapubic hysterectomy. Patient is complaining of uremia due to renal failure, so like that. So you should be doing immediate urethral catheterization. Serum electrolytes should be corrected properly in these patients. What are the indications of surgery? Means prostatism, acute retention of urine, chronic retention of urine with residual urine greater than 200 ml. Complications are hydroureter, hydronephrosis, stone formation, recurrent infection, bladder changes are hematuria. Okay, surgery is transurethral resection of the prostate. Okay, you should be using cystoscope for this, and you should be passing the cystoscope into the bladder. You should irrigate by using fluids containing glycine continuously. Enlarged prostate is identified and resected using a loop with a hand control. Resection is done using a high frequency diathermic current above the level of the veromontana. After surgery, you should also do continuous bladder irrigation with normal saline before you are doing with glycine irrigation. Now you are doing with normal saline. Okay, using three-way Foley's catheter, and antibiotic should be given after that. Catheter should be removed within the 72 hours. What are the post-op complications? So, water intoxication with congestive cardiac failure, TUB syndrome. Due to you are continuously irrigating with fluids, right? So, there may be water intoxication which may lead to congestive cardiac failure. Hyponatremia and hemorrhage, infection, incontinence, perforation of the bladder due to you are passing cystoscope, right? So, it may perforate the bladder or prostatic capsule, stricture urethra, retrograde ejaculation or impotence, and recurrence may also occur. So this is the procedure. See, it is endotherapy for BPH. TUP is the most common procedure. Laser stenting are different procedures. Okay. Next, transurethral resection of prostate. There is no suprapubic incision. Just we are passing cystoscope and irrigation. Okay, it can be used done by using resectoscope. TUB syndrome can develop. Actually, we had discussed what is TUB syndrome before. Continuous post-op irrigation using lysine solution is needed for 72 hours. It is faster recovery and early discharge is possible. Freya's suprapubic transvesicular prostatectomy before TUB it is used. Okay, before in case now there is most commonly we are using TUB. Okay. Complications: hemorrhage, infection, stricture, urethra, incontinence, impotence, bladder neck contraction. Coming to millions retropubic prostatectomy done without opening the bladder. Young's perineal prostatectomy through perineal approach. Microwave hypothermia treatment with temperature of 45 to 50 degrees is a treatment, and placement of intraurethral stents at prostatic urethra. High energy electromagnetic treatment. Placement of extraurethral stents which are inert. Transurethral balloon dilation of the prostate. If patient complains with the acute retention of the urine, initial urethral catheterization is done. Not possible, then suprapubic trochal cystotomy, ideally or formal suprapubic cystotomy is done. The specific problems are retrograde ejaculation, erectile dysfunction, failure, recurrence of symptoms, and enlargement. Need for reference TUBs or surgery in 10 years. Severe sepsis, recurrent late urinary infection, and post-op hematuria needs transfusion of blood, and mortality in TUB is 0.5%. Other methods used for benign prostatic hyperplasia: transurethral incision of the prostate, laser ablation, transurethral microwave therapy, transurethral needle ablation using high frequency radiotherapy, and high intensity US energy, and water induced thermotherapy using a balloon placed in the prostatic urethra, prostatic stents, balloon dilatation. Drugs we had already studied in pharma and path also. Alpha 1 adrenergic blocking agents which inhibit the smooth muscle contraction of the prostate. They reduce the bladder neck resistance as to improve the urinary flow. These are act on dynamic component and reducing the symptoms of dynamic component. Short-acting drugs are prazosin and indoramine. Long-acting drugs are ferrazosin and terazosin and doxazosin. Selective alpha-1A adrenoceptor blocking agent tamsulosin 0.2 to 0.4 mg OD for 12 weeks. 5-alpha reductase inhibitor inhibits the conversion of testosterone to dihydrotestosterone, effective in palpably enlarged prostate. Finasteride, which is 5-alpha reductase inhibitor, 5 mg daily should be given. So duration of treatment is 6 to 8 months. This act on static component indicated in obstructive uropathy or carcinoma. That is this, guys. So even prostatic abscess may develop due to the chronic retention of urine in case of BPH, and the BOO may develop bladder outlet obstruction. So mainly I thought to discuss about benign prostatic hyperplasia. So prostatitis we will discuss later. Okay. That's it, guys, today. I hope this video is helpful. So why we had started with clinical features means if a clinical scenario may provoke interest in you to know what is the pathology, what are the clinical features, what investigations, what surgeries are done. So this is for today. Okay, meet you tomorrow. Thank you, guys. Thank you.